We
Yes.
can.
Mhm.
Okay. Well, welcome. Look at this. There's quite the crowd of seronegative patients today. So some of you have were at the conference on Saturday. And if you were at the conference on Saturday, then some of what we talk about is going to be a recap. And that's okay if you end up thinking that, look, I think I've already heard this, and you want to sign off, please feel free to do so. We are a smaller group right now, and as we go slide by slide, I would really invite conversation. Do I have a moderator?
Yes, it's me, Dr.
Me.
Susan.
So Susan, how do you want to invite conversation? Would you like people to just raise their hands on their video? Do you want them to use the app?
If they could put the messages into the chat if they like conversation, or they can certainly raise their hand if they know how to do that. Raising your hand is one of the on the iPad is along the top, along the bottom on a computer, and it is, let me tell you what it is. It is, I think it
Yeah.
says raise hand.
Mm.
I think it's react, right?
No, it's next to that, raise hand.
Okay, I
On
reorganized.
mine. It's
So
on mine, it's between react and share. But
And honestly, if you just raise your physical hand,
yeah,
I'm sure someone will see you.
yeah.
mhm.
I've got everybody up. So if you, certainly we want to be able to have conversation because this is one of the first times that we've really had somebody speaking on seronegative about, what's coming. So we want to make sure that we have conversation.
Okay, so with that, we're doing a seronegative myasthenia gravis update. Again, I'm Amit Sachdev. I am at Michigan State University, where you can see my litany of titles. Perhaps the most important one is the Muscular Dystrophy Association Clinical Center of Excellence Director. From that, I derive the clinic that gives me the most satisfaction, which is my MDA clinic. Myasthenia gravis is one of those diagnoses that is covered by the MDA. And I have about 150 patients with myasthenia gravis who see me each year, about 250 who see our practice. So my partners see some cases. And that's where we see the really broad array of disease. So we're very pleased to give you an update today on what's going on in seronegative myasthenia gravis. Of course, we always open these sorts of sessions with disclosures. And so here are some of the disclosures that I have. There are boards and organizations for which I may be a trustee, or I might be a member of those boards. There are granting agencies. Those agencies fund various elements of what I do at the university. Those contracts are all with the university. They're not with me proper. But I am listed as the university's agent to execute those contracts. And certainly my bosses look at me kindly when I bring in a clinical trial. And it is one of the reasons I get to do what I do. And then some of the pharmaceutical companies do ask for my opinion regarding various aspects of drug development, of marketing, of patient need. And they ask me to educate other physicians or other providers, nurse practitioners and PAs and what have you. And so this is a list of some of the companies that have in the past asked me to do that for them. I do need to make everybody aware of two things. The first is confidentiality agreements. So because I am a principal investigator on clinical trials, the companies that we do clinical trials with share with me information about their science, and that science is not public information. And so because it's not public information, I cannot share it with you. Similarly, when we talk about forward-looking statements, this is investor jargon. Because I'm in possession of non-public information, I can't make predictions about the way clinical trials ultimately will play out. And if there are investments that people make, they take on risk as a result. My personal investment strategy, I do have investments. I do not manage any of them on my own. They are managed funds or mutual funds, but I have no idea what I personally own. Okay, so now that we've got all of that stuff out of the way, we'll get to seronegative myasthenia gravis update. I would invite at this time any questions or comments regarding the first few slides that we just presented about disclosures and conflicts of interest.
Seeing no questions at this point, Dr. Sachdev.
Very good. Let's get into the meat and potatoes, shall we? So there are stages of this talk. This is generally how I like to set up talks, is to tell you what we're going to do. So first, we're going to talk about measuring MG. So that's just going to make sure that everybody who is attending today is on the same page about how we measure the disease. Then we're going to be talking about the ADAPT Seron trial data, that is with efgartigimod. We'll be talking about Immunovant's clinical trial, ARC, and then Cladrabine's clinical trial. So stage one is measuring MG. So there are three scales that we think about when we think about measuring MG. We think about the MG-ADL, the QMG, and the MG Pro. So as I said, for those who participated in Saturday's talk, some of this is going to be a recap or rehashing. So this is the MG-ADL. The MG-ADL looks at the burden of myasthenia gravis over 8 metrics: talking, chewing, swallowing, breathing, brushing teeth and hair, rising from a chair, double vision, and drooping of the eyelids. And it scores each of them on a 0 to 3. And then you sum up the score, and that's your burden of illness over the last 7 days. So importantly, the questions here are, at any point in the last 7 days, did you, for example, have a meal where you were chewing, and chewing with soft foods was difficult for you, it tired you out? So perhaps though that is yogurts rather than steaks. And if that has happened in the last 7 days, then you score 2 points in line number 2 here, chewing. If over the last 7 days, 21 meals, you've done generally okay with the soft foods, but the chewier, more solid foods gave you pause and you slowed down, then that's a 1. What's really important here is each point matters. So with the MG-ADL, it's meaningful to patients if when you are brushing your teeth or your hair, you can keep on going, but it just feels a little tiring, or you have to stop and take a rest. So that's a meaningful difference between 1 and 2. Similarly, if you have to rise from a chair and you always have to push off with your arms versus someone has to help you get out of a chair, that's again a meaningful difference. So each point in the ADL really makes a difference, and this is why the MG-ADL is structured the way it is. QMG. So the QMG is the provider-guided physical exam. So this is where your physician or your nurse practitioner, your PA, they're examining you. How should they perform the various maneuvers in order to tease out if you have fatigue or not? And so, for example, I like to point out right arm outstretched to 90 degrees. That's like this. Right arms outstretched 90 degrees. You should be able to hold this position for 4 minutes, 240 seconds. If you can't hold that position for 4 minutes, then anything short starts to score on the QMG. And so patients who have double vision immediately, spontaneous double vision, right? Patient looks all the way to the left, has double vision. That's 3 points on this scale. Develops double vision within 10 seconds, that's 2 points. What's really important about this scale is it teaches us that we miss a lot of mild myasthenia. And mild myasthenia takes a lot from our patients. Myasthenia gravis patients are generally underemployed. And they're generally underemployed because we allow mild myasthenia to be present. We don't push to minimal manifestations. And mild myasthenia impairs day-to-day function. Minimal manifestations, to go back to this MGADL, is a score of 0 to 1. So over the last week, at most, you would say one out of these areas impacted your day-to-day function. That is the goal of treatment in my clinic. Our latest clinical trials suggest 33 to 40% of patients should get there. And if you're not there in my clinic, we talk about what might be the next step and whether or not that risk is worth the potential benefit. So if you have a patient who's scoring 4 and it's all ones across half of these metrics, that patient might say, I don't want to suppress my immune system more. I'm comfortable with the level of control I have now and weighing it against the level of risk. And that would be perfectly acceptable, but a 0 to 1 is the goal. If you're short of the goal, there needs to be a conversation as to what could be offered and is that within your best interests or something that you are interested in trying. QMG teaches us that our routine physical exam often misses mild myasthenia. Nobody is sitting there having you stick your arm out for 4 minutes. Nobody is having you stare off to the side for 61 seconds. Actually, I did that twice today. I had a patient do a forced stare for 61 seconds. I saw 2 myasthenics today. So we're really missing mild myasthenia. The last scale, the one that's emerging, is the MG Pro. And the MG Pro is really trying to learn about fatigability. And it's weighing towards fatigability. And that's this component down here, this questionnaire component on fatigability, physical fatigue and muscle weakness and fatigue. And so the MG Pro is really trying to get at that concept of I might not have double vision at all throughout the week, but my muscles just feel heavy. Okay. So to recap, scales help us talk about myasthenia gravis in an organized way. The MGADL is activities of daily living over the last 7 days. The QMG is the physical exam. The MG Pro really talks about fatigue. Okay. Before we go any further, any questions on these scales?
If you'd like to ask a question, you can certainly raise your hand and we will unmute you, or you can unmute yourself and ask your question. I'd like to see how many people have had to hold their arm up for 4 minutes. Show of hands. Not many, Dr. Sachdev. Lauren.
Lauren has her hand raised.
Yep. Thanks, Lauren. But very few of the people on, at least the people that I can see their profile, have raised their hand.
So the one question that we get sometimes on this MGADL is what if I have like a rotator cuff tear? And because I have a rotator cuff tear, I can't brush my teeth like I should. In that instance, that component of the MGADL is not going to score normally, but it's also not going to change. Right. And so this is why we say if you could get to a low score, if you could get to a score in the mild range, a 0 to 6, then we should have a conversation. But it may not be mandatory that we change what we are doing to control your disease. So and it may be obvious at that point, like, okay, well, sure, we're not at a 0 to 1, but the orthopedic doc has to do their job. Or if you know that you have a swallowing issue of some sort, achalasia, for example, where you have a narrow esophagus at the top. Well, okay, then you're going to have some choking episodes every now and then, and that's not myasthenia. So if you're only scoring on that, we'll say, well, the likelihood is the myasthenia is out of the way. And we would encourage you at that point to go work with the GI surgeons because your myasthenia is really stable.
Lauren, do you have a question?
I did.
Go ahead.
You mentioned that the burden for the last 7 days for the
Yes.
first test,
Yes,
is that for all of the test? Is the 7 day time span?
No, so the QMG is a spot test, right? So this is you're in the office and we're examining you right now.
Okay.
So the QMG really reflects how you're doing this moment. But what I will say is that most of the time, if you have fluctuating burden of illness with myasthenia, it's because you have inflammation blocking that nerve and muscle junction. And you might have tuckered yourself out last Tuesday, but I can tucker you out with this study, right?
Okay.
So because you're not in a normal state right now, even if you're having a good day,
Yeah.
right? And that should be, again, I'm gonna have you lay down on the bed and then lift your head up off the bed for 2 minutes. I will successfully tucker you out.
Yeah. Nobody has tried that.
Right.
They say, "Oh, you're doing well." I'm like, "Yeah, I am today, but can I come in your office when I'm having a bad day spontaneously?" No.
Right. So the problem with the QMG is that to do the QMG, it takes 45 minutes.
Yeah.
And so I have research associates who do this for me. Um, and I don't, when in the routine clinic visit, I don't do every element hardly because no one has that kind of time.
Yeah.
But I will break out one of these techniques if I'm trying to understand if your leg weakness is because of myasthenia, or is it your sciatica, or is it your hip joint, right? Is it SI joint dysfunction? Then I might pull out the leg raise and see if you can hold it for 100 seconds. And if you can't, but you can't because you're saying, Doc, my hip just hurts a lot, and I push over your SI joint, and you say, ouch, and yelp and hit me, uh, then then it becomes pretty obvious what kept you from holding it up for 100 seconds. So this is the way the QMG helps us learn about a patient.
Okay. Thank you.
Yeah, of course. Other question?
Do you remember what he said? The fluctuating influence. Um,
What was the question? Who just asked the question?
Oh, no, sorry, that was me. I didn't
Okay.
need to mute myself again.
Okay,
Thanks.
so
Dr. Sachdev, your sound went a little bit like it's muffled.
is this any better?
Not really.
That's curious. I don't think anything changed on my end.
There it
Oh,
goes.
that's better.
Now it's back.
It's back.
Yeah.
Okay. Apologies. Okay. So next we're going to talk about adapt seron. So there is not a whole lot to talk about with adapt seron, unfortunately, because they've not released the data set. But I'm gonna set this up for you. Okay, so what is adapt seron? So adapt seron is the efgartigimod study in seronegative myasthenia gravis. So what is efgartigimod? Efgartigimod is marketed as Vyvgart. So efgartigimod was approved in 2021 for patients who have anti-acetylcholine receptor antibody positive generalized myasthenia gravis. So those are the people who have the positive blood study. Everyone who has joined today's call is seronegative. So Adapt Seron was attempting to recruit 119 seronegative patients to see if they could replicate the findings of the Adapt study in the seronegative patient population. Why did they think that they had a shot? Because they did have a few seronegative patients in the Adapt study, but not enough to make and go for an approval at that time. And they felt that there was a trend towards improvement with the few seronegative patients they did have. So the primary outcome measure for Adapt Seron is that MG-ADL. And in order to enter Adapt Seron, you needed an MG-ADL score of 5. And so 5 or greater. So that's patients with mild disease or worse. And the way that patients in Adapt Seron got the efgartigimod, the Vyvgart, is they received once-a-week infusions every week for 4 weeks. Then they had a 5-week follow-up and then an analysis of what happened to their MG-ADL. Now, the next question is, well, what happened? Well, actually, the first question before that is, what was seronegative? So for Adapt Seron, seronegative meant anybody who did not initially qualify for the first Adapt program. So that meant MuSK positive patients, LRP4 positive patients, and patients with no detectable antibodies of any kind. Those were all included in Adapt Seron. The goal of Adapt Seron was to expand the label for efgartigimod, again also known as Vyvgart, to include these 3 populations, MuSK, LRP4, and triple seronegative. So the results are that, in fact, it appears that patients who received the efgartigimod did noticeably better with respect to their MG-ADL than patients who got placebo. And this p-value right here, 0.0068, this is a pretty strong showing. So there was, I think, then what we can infer from here is that there's a clear difference between having seronegative myasthenia and getting efgartigimod versus having seronegative myasthenia and getting placebo. What we don't know, though, is how big of a difference, because they haven't released that data yet. So this is the extent of what they've released, is that it appears that efgartigimod in this clinical trial was superior to not giving a patient any FcRn inhibitors. Now, to get into this study, patients needed to be treated in some way. So that could have been pyridostigmine, that could have been corticosteroids, that could have been oral T-cell inhibitors. So they needed to be treated in some way. And then they added efgartigimod on top of what they were receiving today. Okay, what about safety, right? So it does appear that the folks who were in Adapt Seron had a very similar safety profile to the patients who were in the main Adapt study. So that means there is a meaningful increased risk of infection. There is an increased risk of allergies or hypersensitivity reactions to the drug, and there's a risk of infusion-related reactions when you put the
Doctors that I
drug
did
in.
not have because I did not have a positive.
I think someone else's microphone may be on.
I muted.
Oh, okay, very good. So infusion-related reactions was the last bucket of safety considerations. Again, we don't have the data yet. It's not been shared with me, so I can't tell you exactly what the percentages are. Just that the press releases are saying these were comparable in rate to what has been seen with patients in the initial exposure of efgartigimod to acetylcholine receptor antibody positive myasthenia gravis. Okay, so this isn't the first data set for all of these patients. We know that anti-MuSK patients currently have access to rozanolixizumab, also known as Restigo. So what did this data demonstrate for those MuSK patients? Over the course of this trial to week 6, patients with placebo appeared to have actually a worsening of their MG-ADL. Patients on a low dose of rosoxinilumab had a 7-point reduction in their MG-ADL, and on a high dose of 4.2-point reduction. So you can see the numbers are very small, right? 8, 5, and 8. So this data set is small. This data set was enough for the FDA to approve this agent for patients with anti-MuSK myasthenia. Rozanolixizumab, also known as Restigo, is a competitor to efgartigimod, also known as Vyvgart. Those two drugs belong to the same drug class. They're both FcRn inhibitors. So it appears that the ADAPT-CIRRON data would be consistent with the data for rosoxilumab. And together, that would give us some added consistency that perhaps the use of FcRn inhibitors may in fact benefit patients who do not have traditional myasthenia gravis autoantibodies. And from the ADAPT study, perhaps even patients who have no detectable antibodies, MuSK, LRP4, or acetylcholine receptor. Okay, so this is the composite slide for stage 2. So the ADAPT-CIRRON results have yet to be fully released. Those are again with efgartigimod, also known as Vyvgart. Public releases suggest that the data is strong enough to seek an expanded FDA label. So argenx, which makes efgartigimod, has said publicly they think they can expand their label to include LRP4, MuSK, and true antibody negative patients. And their data, at least their claim, would be consistent with what has already been seen in another FcRn inhibitor for MuSK patients. Okay, so let's pause there before we move on. Questions about ADAPT-CIRRON, efgartigimod?
Dr. Sachdev, I'm going to ask a question that's been asked of me many times, that seronegative patients in treatment from a current doctor that they have indicated that the doctor does not actually think that they have MG and has limited the medications that they are eligible for or treatment in general. And I think that has been kind of a common question is, how do I know that these people think that they have MG and likely and have all the symptoms that would go with MG and of course do the MG-ADL, but how would their doctor view them based on the current status of how the doctor is treating them?
Yeah.
And you may not be able to talk about that because it's also, of course, another clinician, but I think you understand kind of what I'm asking is, if you are excluded from a lot of these things, how do you know you would be included in ADAPT-CIRRON?
Yeah. Okay. So the first question is, do you have myasthenia gravis. And there are a couple ways to try to figure that out. So certainly, if you score on the MGADL, then you would start to think to yourself, well, this instrument was specifically designed for myasthenia gravis, and now I have some suspicion that maybe I might have this. And then you would want to take that suspicion to your doctor. Your doctor might confirm the disease in a couple different ways. The first is just clinical history and physical exam. The second is the blood work, as we've talked about. So that's the acetylcholine receptor antibody, LRP4, and MuSK. Next is EMG. So the EMG could have either the repetitive stimulation or the single fiber EMG. So those two techniques would help tease out if nerves are talking well to muscles. The final thing that could be considered is genetic testing to think about congenital myasthenia gravis. These are the different ways, at least, that I ask the question, could someone have myasthenia gravis? If the answer is no across the board, then it's pretty likely that this is a different disease. And so, but if you have gone short of that testing, and it seems that other testing has argued against other diagnoses, it may be reasonable to seek an additional opinion or to expand the testing until you get through really the whole gambit.
Anybody else have any other questions? You can raise your hand or you can unmute yourselves. I think that this conversation is one that, I've had with many, many people about, where they are in treatment for a disease. Lauren, you can unmute yourself. Should ask to unmute you, and there you go.
Okay. So what other diseases does this get confused with often?
Okay, so the motor network starts up high in the brain. And so in the brain, we have the homunculus, that's your strip of brain that creates motor signals. And if you damage that strip, you will have dysfunction. So diseases like multiple sclerosis or strokes will damage the strip. Now, the challenge there is damage to that strip usually causes symptoms that come on and stay for a while. They don't fluctuate, especially within the day. They don't have a tendency to fluctuate. But that's the first place we think of, is motor strip, MS, and stroke. Now, those signals go down to the internal capsule. That's another place that can get damaged. The injury there is a fairly common kind of stroke called a lacunar infarct. That's where a very small blood vessel of the brain just gives out. Little blood vessels are under blood pressure and cholesterol and time, and with time they just stiffen and eventually they can just clog. So lacunar infarcts are on the list, but usually that presents with weakness in half the body. Then those signals go down to the brain stem. Brain stem infarcts can cause drooping of the eyelid, double vision, and so that gets placed on the list. Then from there, we go down into spinal cord. So central canal stenosis, that's where a disc goes straight back and pushes on the spinal cord. That can cause weakness of the body and a phenomenon called claudication. So if your spinal canal is really narrow and it's pinching around the spinal cord, and the spinal cord rubs every time you walk, then that rubbing causes inflammation and causes a sense of disconnect. The further I walk, the less control I have on my body, and my body is going to collapse. So if that starts to sound like myasthenia, it's because it's in the differential diagnosis, right?
Yeah.
Then we get down to nerve root. So from the spine, nerves come out. Nerves can get pinched as they come out, but that usually causes regional problems. Like I have shooting and weakness in my upper arm. And then we have neuromuscular junction. So the nerve comes out, attaches to muscle, and that's where myasthenia lives. And then we have muscle diseases. So that's polymyositis and dermatomyositis. That's where the inflammation is actually physically damaging the muscle. And that is the motor strip. And those are the various things that most commonly we think of when we are thinking about a problem with the motor strip.
I had a diagnosis of myasthenia gravis, seronegative, but then the next neurologist I was recommended to didn't believe in it. And so they thought that I had functional neurological disorder. So now I'm going to go see a third person.
So that is unfortunate. Is it a possible diagnosis? The answer is yes. But functional neurologic disorder is a diagnosis of exclusion. You really do need to interrogate this the system that helps you move from brain down to muscle before you issue a diagnosis of functional neurologic disorder. I am on a support group in one of the social media channels, and I do see a good deal of stories from patients who were initially diagnosed as functional neurologic disorder and ended up diagnosed with myasthenia gravis. And that is a really unfortunate outcome.
Thank you.
I think that that is one of the things that a lot of people are wrestling with, because sometimes it's the default becomes functional neurologic disorder rather than examining all the things that you just talked about through examining what might be going on, because it's an answer that means that they don't have to treat them for MG. And I think that that is a common thing that patients have told me.
We have another hand.
Carrie, you want to unmute yourself? Just a second. Let me find you. Oh, there you are.
Yeah, I was just gonna say, I've had the same situation, and if you're in that situation and you're not confident in your diagnosis that you're getting from the doctor, it's probably best to just keep looking for another doctor until you're in agreement with what they diagnose and what you feel. I think I went through 8 different neurologists in Detroit before I found one that was really willing to take the time to figure out what it was. And it was myasthenia gravis.
Unfortunately, that's not a common path to diagnosis. Sometimes that's, a number of years. I think what the reason we're having this conversation now is we're hopeful that that will be different. And I also think there's never a reason to not have, or there's always a reason to get a second opinion if it doesn't explain, or there's not a treatment for what you're experiencing. I think second opinions are sometimes we just now know more. And so that ability to know more and find somebody who is at Dr. Sachdev's level, I think that that becomes something that allows somebody who has that amount of knowledge to be able to do a different exam that you may not have had earlier.
So my next question is, how do I get signed up with you? How can I see you?
I think there's a slide at the end
Yeah.
that
Yes,
talks
there
about that.
Thank you.
And
is.
And it's a specialty clinic in MG, but you know, that's why we're having this conversation now. Ron, you can unmute yourself. You should be able to.
Okay, thanks. I was going back to the ADL, I think it's the ADL scale, and I've been being treated for a while. Actually, I don't know if you remember me, Dr. Sachdev, but you basically saved my life back in 2023, the summer of June, at Sparrow Hospital, and then you got me stabilized, and then I've been seeing Dr. Ramaswamy and taking Panzyga, and I can see where on that scale now what she was doing, and I got to find out my numbers and stuff. But I know the last few times she was very pleased with my numbers. She said have come way down. I was just going by my overall function and what I could do and how I could get around has gotten better. But like how long do you said the goal was what, 0 to 4 or 1 to 4?
0 to 1.
Or it was 0 to 1. Oh, I see. Wow, that's really everything gone then. Okay, how long of a duration until is the goal? I mean, what's the normal duration to get down to that goal of 0 to 1?
So it really depends on the medication in question. So for
Okay.
example, if you're on the medication mycophenolate, that drug takes 3 to 6 months before it even starts to change your disease experience. If you're on the medication azathioprine, that drug takes 9 months before it begins to change your disease experience. Whereas, for example, if you're on corticosteroids at a high enough dose should change your disease experience pretty quickly, 3 weeks, something like that. But can cause side effects which may interfere with perhaps the assessment of the scale.
Okay.
So it really depends on the particular intervention for how quickly we expect it to land its effect.
Okay, thank you. Yeah, when you named those medications, I guess I was pretty bad off there when I was in the hospital, and then I was on all those medicines, and then when the Panzyga, I got started in the Panzyga, Dr. Ramaswamy, we've been decreasing the prednisone, and she said the goal was to get that down to I'm going to be off of it. And then that one, the AZA one, she said I'll probably have to keep taking forever. So and I'll be into I'll be into C eventually. But anyway, I was just curious. Yeah, I was, because I mean, I could see, I'm going to find, it'd be interesting to see what my numbers are, like I said now, but I know my number was way up and then it's down way considerably for that. So, and then my overall day-to-day function, I mean, still have periods when those things hit, but not nearly as much as they used to be. So anyway, that answered my question. Thank you very much. I appreciate you very much. Thank you.
Thanks, Ron.
Any other questions before we move on to the next section? Okay, so hearing none, we're going to start to talk about the 2 clinical trial programs that I am aware of that are allowing seronegative patients in. So the first is the Immunovant 1402 study. So you can't talk about Immunovant 1402 without talking about Immunovant 1401. So what is Immunovant 1401? So Immunovant 1401 is also known as batoclimab, and this is a FcRn inhibitor. So this drug belongs to the same class as efgartigimod, also known as Vyvgart, and rosoxilimab, also known as Restigo. So this drug would be yet another medication in that same drug class. Again, I am privy to non-public scientific information, so when I give you these results, I have to sort of copy and paste from the website of the various companies, and that's why this is so wordy. But I'll translate it for you. So in the batoclimab clinical trial, so the batoclimab clinical trial is a phase 3 study. That's a pivotal study before approval. This study started in 2023 and had a data readout already. And what we know is that this is a big study of this new FcRn inhibitor. And the success on this study was measured based on MG-ADL score. And the MG-ADL score in the acetylcholine population dropped by 5.6 points on average in 12 weeks. So what this really argues is that there's a meaningful impact on disease activity in this antibody positive patient population from 1401. So you're not going to see 1401 for sale. You're not going to see batoclimab submitted for its next approval. And the company made that decision because they were concerned about some of the nuances of 1401, specifically that 1401 seemed to drive up cholesterol levels. So this was a unexpected finding that they ended up seeing in the clinical trial programs. And because they saw this in the clinical trial programs, while they thought that the drug was effective, they felt that if they were going to go to market, they needed to work on this particular challenge of cholesterol levels.
Mhm.
So we go back to this MG-ADL score, where patients who were given the high dose of 1401 had on average a 5.6 point improvement. So you can imagine, what does 5.6 points look like, right? I mean, there are lots of different permutations here, but you could go from, fatigue with soft foods to no issues of chewing, plus shortness of breath at rest to nothing, right? So, I mean, you could eliminate entire categories of symptom, or you could take a bunch of mild symptoms and eliminate them. 5.6 points is meaningful on this scale. Pretty much any way that you cut it, it would be meaningful. So that performance is pretty encouraging. And so 1402, we don't know the exact chemistry of how 1402 is different from 1401. But we do know that 1402 is their next attempt at an FcRn inhibitor. And at least in their animal studies, they're claiming to have minimal to no impact on cholesterol levels. Yes, Carrie.
So I just found out I now have high cholesterol. Would that exclude me from this study?
So there are in the inclusion criteria some need to be within certain parameters for cholesterol. But usually that is achievable. So if someone is on an anti-cholesterol agent, that usually they can bring it down to whatever it needs to be. I've only ever had one screen fail on cholesterol, and that's in the history of my doing clinical trials. And we've certainly had patients who came into clinical trials with modestly elevated cholesterols to begin with.
Okay, good, thanks.
So the 1402 study is a study that is open and recruiting now. This is the clinical trial ID number, and this is the name of the study. We are a site for the 1402 study. The seronegative patients are being metered. So they can't have the whole study be seronegative. It is open to seronegative as well as seropositive patients. And we need to get permission from the company for each seronegative screen we do. But that said, we have a fairly good working relationship with Immunovant. And I'm very comfortable saying that we have a strong line of communication. And if we bring them a good candidate, they will have that conversation with us. So how is this study structured? All studies have a placebo portion. So what you have here is you have 1402 low dose. That's one subcutaneous injection once a week for 12 weeks. We have 1402 high dose. That's two subcutaneous injections a week for 12 weeks. And you have placebo. That is, you still get injections, but there's no drug in the injection for 12 weeks. So there's a placebo-controlled portion for 12 weeks. 1/3 get low dose, 1/3 get high dose, 1/3 get placebo. After that point, everybody gets drug. And so even the placebo portions go into 14 weeks of drug. And then after that point, there's an open label extension. And that open label extension is for a year. And so everybody gets drug for a year in that phase of the study. So that is quite the commitment that the company is making to patients who are willing to endure the placebo-controlled portion of 12 weeks, that there is then drug available to them for a decent period of time thereafter. Okay. So the wrap up on Immunovant, 1401 was the first study that was done, and it appears to have performed positively in its study. 1401 had some challenges. Those challenges were really around elevated cholesterol. 1402 is Immunovant's next attempt, and at very least, they have publicly said that their animal data suggests that they do not have the same challenges around cholesterol. The study for 1402 is structured very similarly to the successful study of 1401. So the company feels like they have found a successful way to run these studies. So they're really replicating the 1402 study more or less identically to the way they ran 1401. And what that means is a 33% chance of placebo in the first 12 weeks. But then there is all placebo patients flip to drug, and then there is the open label where everyone knows exactly what they're getting. Okay. Questions about the Immunovant study?
Carrie, go ahead.
With the placebo portion, let's say I get in the study and I get on the placebo portion, and 8 weeks in, I dramatically decline. Do I go on drug? Do I leave the study? How does that work?
Yeah, so relapses do happen, and relapses are managed with a protocol. So for the most part, to get into studies like this, you are allowed to keep the medicines that you're on. There are a few exceptions. Clearly, if you're on another FcRn inhibitor, if you're on a Vyvgart or a Restigo, or an Imavi, also known as nipocalimab, it doesn't make sense for you to be on this one, right? So you can't be on one of those. Unfortunately, you can't be on IVIG as your maintenance strategy. And so if you are presently on IVIG, then an alternative treatment strategy would have to be instituted before you ever considered the study. Same with plasma exchange. So these are very true of most of the studies we run. So those are challenges where we would have to figure out what the patient is on before they ever enroll into a study like this. Now, if they are in the placebo-controlled portion and they have a relapse, most studies have a protocol, and typically that protocol is rescue with IVIG, or plasma exchange. And so we would follow that protocol. You would be rescued. and most of the time you would stay in the study. And so because for these studies, a dropout is a really big deal, huge deal, actually. So we really want, if you're going to start in day 1, we want you to make it all the way to week 26. And if your disease experience was relapses and you had to get rescued, that needs to be a part of the data set. So it would be uncommon for a patient to get kicked out because they had a relapse. Does that help?
Yeah, thank you.
Right, I just want to notify everybody, we're going to be running a little bit longer because of our late start and our conversation, but I still think that it's worthwhile staying on. It'll go a little bit after over an hour, but we're coming to the home stretch with some really good information.
Yeah, thank you for that, Susan. I was actually going to say exactly the same thing.
Okay.
We think very similarly. Okay, so the last section in today's talk is cladribine. Okay, so cladribine, we're going to talk about how does it work, some of the details around its current package insert, some of the data that's publicly available to date, and its potential role in MG. So again, if you attended the Saturday talk, some of these slides are a repeat. Cladribine is a chemical. And what it does is it disrupts the ability of a T cell to replicate its genetic code. And so it disrupts the DNA of T and B cells. And as you can imagine, if you go in there and you disrupt DNA, then that is just the basic machinery that you need to run a cell, and those T and B cells are going to die. And so, again, straight from the website Mavenclad, which is the trade name for cladribine, temporarily reduces the number of B and T cells circulating in the body, so there are fewer such cells attacking. So this is a pretty substantial injury that is inflicted upon your immune system. And there are some challenges that go along with inflicting such an injury. This is the black box warning from the package insert. So this is the currently approved package insert for the FDA. And it warns about malignancies, which is cancers, and teratogenicity, that is risk to pregnant women and risk of fetal harm. So the risk for malignancies is largely hematologic or bloodborne malignancies. And I mean, you're significantly damaging the bone marrow. The immune system comes from the bone marrow. And then it's not necessarily out of the question that as the bone marrow recovers, that it may not recover in a normal fashion. So this is something that we have to screen for. And then teratogenicity really revolves around what is unknown about how a fetus develops and how damaging it could be to expose a growing fetus to a drug that disrupts DNA. So, so to date, there has been at least a pilot study in 2019, and the pilot study used a scale I didn't actually demonstrate to you. It's called the MGC, which is kind of a composite of the QMG and the MGADL. And the MGC dropped fairly substantially in patients who were exposed to cladribine. So you can see a drop from 15.1 to 6.3 points within 4 months. So whatever scale you use, if you have a 60% drop in disease burden, that's going to be a lot. And so if we look back at that MGADL and we said you went from, 12 to 5, that would be enormous. And so this is a pilot data, and it's a relatively small sample of 11 patients. But then again, we saw with the Restigo data set, the rosuximab, that to get the Musk indication over the finish line, they had a total of 20 patients. So when we talk about how much data do you need in myasthenia gravis, in particular for uncommon variants, this might be around sorts of numbers that one could start to talk about. And another big deal with these patients is they were measured on how much steroid they required. And in this data set, the average decline of steroids was about 80%. And over the course of this study, patients did not experience relapses. So this sort of study is small. It's by no means perfect. But it speaks to the possibility of what we see in other areas where cladribine is approved, which is multiple sclerosis. The reason that it's used and used fairly widely in multiple sclerosis is that it provides a fairly durable treatment effect. Patients seem to get better and hold on to their gains for a long period of time. It's not without risk, but there is reward, it appears, for many patients. And so that is the potential. That's why we should think about running the study. So when we think about patients who prefer this approach for multiple sclerosis, patients who are refractory, they've tried other drugs, they're not working. Patients who are challenging, maybe they have multiple autoimmune conditions, or patients who are having trouble with managing other medications because of the burden of healthcare. Cladribine is oral. You take it 5 days in a row, days 1 through 5. Then you take it a year later, days 365 to 370, and that's it. And you have annual checkups through years 3 and 4 and on to year 5. So 10 treatment days, 10 days where you take a pill, and then monitoring for 5 years.
Wow.
So you can see how, yes, there are risks, but one can start to understand what is the possible reward. And especially a patient who is complex, who is young, who already has severe disease and is looking at disability, they might consider these options. So this is a study. This is the study. It's the MyClad study. It is open and enrolling. Though our site is not yet open, we are considering this study still. This study is allowing seronegative patients. And there are several sites across the United States that are enrolling. So to recap, this drug, cladribine, does appear to have a significant, but not necessarily dominant market share in multiple sclerosis. It's really driven by high efficacy oral administration and a very short course of treatment. It does require ongoing monitoring. Early data in myasthenia gravis is supportive, but definitely not definitive. That ongoing monitoring is a big deal. I mean, we're talking about, risks around pregnancy. We're talking about risks of malignancies. This trial does enroll seronegative patients. And so before we go on to just recap, any questions on cladribine?
Dr. Sachdev, I have a question because I'm familiar with it from MS. It's considered a disease-modifying therapy for MS. Are they thinking that it would be a disease-modifying therapy for MG? And would this be, if it is successful, it would be the first disease-modifying therapy?
Well, we don't, so this sort of terminology I wouldn't necessarily use. the terminology I would use would really be around maintenance. So is this a therapy that can improve the experience of disease maintenance? Because all of our therapies are really focused around maintenance.
Thank you.
Mhm. Other questions about cladribine? Okay, so let's do our recap then. So MG is measured using scales. The MG-ADL is the most common one. The ADAPT Seron data, at least publicly released, appears to establish efficacy of efgartigimod in seronegative cases. But the vast majority of data has yet to be released, and I can't tell you anything about the magnitude of effect. At very least, I can say that that claim that efgartigimod has advanced is at least consistent with another data set, that's rosoxilumab's. And rosoxilumab's pivotal study was enough for the FDA to approve its data set for musk myasthenia. There are two clinical trials that I am presently aware of that are enrolling seronegative patients. The first is the Immunovant 1402 study, which is an emerging candidate that's enrolling seronegative cases. And the second is the cladribine study. Immunovant 1402 is an FcRn inhibitor, and cladribine is an existing therapy that is used in other diseases like multiple sclerosis. Okay. And with that, I thank you for your time and for listening. Here are two email addresses. The first is my clinical trial manager, Aubrey Alexander, and the second is myself. I would really encourage you that if you want to get a hold of me, please CC Aubrey, because I get a lot of emails, and I would regret missing a patient's email just because I'm inundated with a lot of other emails. And so please, I'm happy to try to answer questions, but consider also attaching Aubrey to those emails.
Thank you, Dr. Sachdev. Excellent presentation. Even, seeing part of it from Saturday's conference. I'm so happy that we're getting to the point where we're talking about what's going on with seronegative patients, and just giving better patient experience for people who are seronegative, in an effort to really provide therapies for them. Any other questions that anybody had as
I
we?
sent one through chat.
Oh, you
I
sent one
sent-
to chat. Sorry about that. I was not looking at.
That's okay. And it's very basic. This is the question that we frequently get.
The question is, if someone is having MG symptoms, no antibodies are found, and I'm help some by mestinon, does that classify me as seronegative?
So the question here is, if symptoms are there, labs are absent, pyridostigmine response is present, is that enough? And I would say for most clinical trials, it's not enough.
Okay.
For most clinical trials, you would need the EMG to also be positive.
Okay.
Now, clinical trials is different than the clinic.
Right.
In the clinic, it might be enough based on the robustness of the pyridostigmine response. And so it really, that will require a physician visit and some understanding of exactly how did pyridostigmine help. And usually, if it's felt that pyridostigmine helped a lot, then you take that next step of thinking about either other medicines like prednisone or genetic testing. These are the directions that you start to talk about.
Okay. Thank you.
Mhm.
Thank you.
Thank you, Carrie, for your note. I'm gonna just run through to see if there are any other questions. Looking like there's none.
Wait, I have a question. Sorry.
Go ahead, Lauren.
Okay, so the genetic testing part of it, if I have an aunt who is has myasthenia gravis and she tests positive, I am symptomatic but seronegative, would the genetic testing like prove then that would be I have it too?
So
Or is that genetic component like I'm related to someone with it enough?
yeah, so when we think about family history and congenital myasthenia, we're looking for other members of the family who have drooping of the eyelids or double vision, but they don't have acetylcholine receptor antibodies. So that's the first, is you're looking for additional seronegative family members or family members with prototypical symptoms who never went through the testing process because perhaps just less was known at the time. Now, the second thing you're looking for is really close family members. So we first start out the conversation with siblings, parents, and children. And we don't go all that far beyond those family members. And then when we're thinking about what, like how is genetic testing done, it's usually done with a cheek swab. And some companies such as Invitae offer panels that allow us to test for these genes.
Thank you.
Mm-hmm. And I will say, actually, it's a very interesting topic, congenital myasthenia gravis. So I have about a half dozen, and there is quite the article on the National Institute of Health's website about treatment strategies in congenital myasthenia. The mutations are all responsive to completely different medications, and those medications are totally different than the ones we use in autoimmune myasthenia.
Thank you.
Mm-hmm. But that's a different talk. Very interesting talk. Maybe we'll do that one next.
Thank you.
Mm-hmm.
Thank you so much for the talk tonight. Very enlightening and also exciting that some of the trials that you are considering doing, but also, currently running, it's very hopeful. I did hear that with the AANEM coming up at the end of the month, that it's my suspect that some of those trials will be presented then because that's their big show of at least the data from some of those ones that are trying to be approved. And I would guess that Argenx may be planning that, but it'll be interesting to see and then see if it's approved.
Yep. All right. Well, thank you.
Thank you.
Have a good rest of your night, everyone.
Thank you very
Thank you.
much.
You as
Thank
well.
you.